Yes, Dr.
Okay.
Ferenci, we are online and good to
Well,
go.
I'm trying to get this started. I share the
Yeah.
screen.
You see on the, yes, you share the screen, please.
Yeah.
I can see your
Now,
screen.
okay.
Wilson's disease. Yeah.
Okay. Very good.
Okay, we start. One, two, three, go.
Okay. Well, good day. I'm happy to joining you online to your meeting, which I enjoyed 2 years ago. Unfortunately, these days with all this pandemic, traveling is very difficult. So I hope this will be a time when we can meet directly again. So I'm talking today about Wilson's disease, about the timely diagnosis, treatment, and follow-up. Wilson's disease, the clinical presentation is very variable. As you see, basically, you can have liver disease, any form of liver disease, starting from acute hepatitis, hepatic failure, to any type of chronic hepatitis, cirrhosis, and the special entity is comes negative hemolytic anemia, which is often associated with liver disease. Then you have the large complex of neuropsychiatric disease presentations, mostly extrapyramidal problems like tremor, rigor, dyskinesia. People are unable to write, have a slurred speech. At the end, they have inability to walk. And then there's a whole group which is not very well explored, are patients with depression and psychosis. And you see on this side of the slide that these presentations overlap. In the middle, you have hepatic presentation, and you can have every combination with neurology, psychiatry, and hemolysis with hepatic disease. A very important point for diagnostic purposes is it is not a disease of the young people. You see here from a paper I published 2 years ago, the black bar shows you patients with hepatic presentation and the white bars, patients with neuropsychiatric presentation. And what you can see is that in the age group below 12 is almost exclusively liver disease. In the age group, in the adolescent age group, it's still prevalent hepatic disease. But then after adulthood, it's about 50-50. So you can see here, age about 42, my oldest patient I diagnosed was 79. So it occurs at any ages. This is a very important message I like to give you. How to diagnose the Wilson's disease? Basically, it's a quite difficult issue if not the typical findings are present. Dr. Sternlieb 30 years ago defined the diagnosis if you had Kaiser-Fleischer rings, seroplasmin, and neurologic symptoms. If two were present, they have established diagnosis without any further tests. Now, let's go into details. That's a Kaiser-Fleischer ring here. It's a brownish greenish ring at the edge of the cornea. You may need a good ophthalmologist with a slit lamp to verify the Kaiser-Fleischer ring. And these are our data. You see important message that 2/3 of patients with liver disease have no Kaiser-Fleischer ring. You see, here's one difficulty. In neurologic patients, Kaiser-Fleischer ring is almost always present. Now, there are more delicate methods to detect Kaiser-Fleischer rings. This is Scheimpflug imaging of the cornea. What you see here is the cornea, and you see at the edge the Kaiser-Fleischer ring. And you can quantify it. You see here Wilson's disease with Kaiser-Fleischer ring, Wilson's disease without Kaiser-Fleischer ring, and controls. And the beauty thing about this method, you can use the quantification to monitor the progress of your treatment. You see here, that's the baseline value, and that's after 6 years, you don't see the Kaiser-Fleischer ring anymore. And that's an even more fancy methodology, not new one, optical coherence tomography in Wilson's disease. You see here parts of the retina in this type of examination with several layers here. You see the names of the layers. E and L means inner nuclear layer, and GCP, the ganglion cellular inner plexiform layer. And if you measure the width of each of these layers, you see here a significant difference here in patients with Wilson's disease is much smaller. But that's something for fancy studies. So what about seroplasmin? First of all, seroplasmin has nothing to do with Wilson's disease. It's a very important statement. A low seroplasmin value has a low sensitivity and a low specificity for screening. It's absolutely useless in screening. Tossing a coin is much more likely to show you a positive result. The problem is that seroplasmin levels are increased by any type of inflammation, including hepatitis, and by female sex hormones during pregnancy or in ladies on oral contraceptives. On the other hand, seroplasmin is decreased by any form of lower copper supply, like in celiac disease or in malnutrition, obviously on decoppering therapy, by decreased hepatic production and liver failure, and there's a separate entity called aceruloplasminemia. So what we are interested in is how much copper is free, which is considered to be toxic. And this is called the free copper or non-seroplasmin bound copper. This is a very old formula to calculate NCC from total serum copper and seroplasmin in a serum. It's quite difficult because the units are different. It's micromoles, it's grams. But to make it easier for you, I'll give you a website where you find a very nice copper calculator where you can put in your own data and get the results within 10 seconds. Anyway, NCC is very unreliable. It depends on the determination of seroplasmin, which is a problem. And you find 30% negative values. And therefore, this test has never entered the diagnostic algorithm of Wilson's disease. There are newer methodologies to do it. It's exchangeable copper, where you extract copper by EDTA and give it as percent of total copper, which is a quite good estimate of the free copper. And very new methods use a removal of seroplasmin by specific antibodies and measure copper in the supernate. Urinary copper is simply the simplest test. It reflects the so-called free non-seroplasmin copper bound in the blood. It is only increased when hepatic and possibly extrahepatic copper storage capacity is exhausted, because otherwise there's no copper in the blood and cannot excrete it. And also when copper is released from necrotic hepatocytes. So in any form of acute liver disease, you may have increased copper excretion, and it cannot be measured in anuric patients. Now, about light microscopy for diagnosing Wilson's disease is not a very reliable method either. Light microscopy shows you steatosis. It's a typical feature of early Wilson's disease, and mitochondria, if you have the luxury to have an EM picture of a liver biopsy. And if it is present, and you say, well, there may be NASH, which looks exactly like NASH. You see it here. This should raise the suspicion of the pathologist and at least mention this could be also Wilson's disease. Histochemical staining for copper is of very limited value. Only 27% of slides show you copper staining. So you have to quantify copper by atom absorption spectroscopy. And these are the data for the hepatic copper content. This is possibly the largest study from China. And these are the usual values given as lampposts. If liver copper is greater 250 microgram per dry weight, then the sensitivity is very good. You see in this Chinese study, out of these patients, 168 had Wilson's disease and 15 had not. What does this patient have? Cholestatic disease. If the liver copper is in between, then only 10 had Wilson's disease, and most of them had no Wilson's disease. And liver copper below 50 clearly excluded Wilson's disease. And in this study from China, the best cutoff value was 207 microgram per gram. In the lower part of the slide, you see my own data, a different way to measure copper, the synchrotron radiation microscopic X-ray fluorescence. And you see here the picture of a cirrhotic liver. And the important point here is brown is copper in this slide. And you see it's patchy. So if your needle gets in here, your copper may be normal. And if the needle gets in here, the copper may be very high. I think this is something to be considered, that has a very high sampling error, and you may have to do 2 passes of liver biopsy to be in a good range of diagnostic reliability. A very new way for diagnosis is ATP peptide analysis. These are data I generated together with Dr. Hahn's unit in Seattle in the United States. What we did, we took right blood spots from 216 patients of any type, siblings, babies to adults, and measured by an antibody-mediated enrichment ATP, specific ATP peptide, this one, 1560. And what you can see here on this slide, the Wilson patients, most of the patients have undetectable ATP, or even very few have a normal, but you see here a highly significant mean value as compared to controls. Now, the problem of this study was these are selected patients with known Wilson's disease. So this was not a screening study. And among all patients, 92% were diagnosed by low ATP. So that's a very good yield. If you looked in difficult cohorts, for example, those who had only 1 mutation, it was still 94%. And if in patients with well-confirmed, genetically confirmed, it was 91%. The problem is that some mutations do have normal ATP values. So I think it's not 100%, it's just a 90% method. And even in patients with normal seroplasmin, 88% have a low ATP level. This is a very simple test. You only need a blood spot. It can be automated. And hopefully there will be a commercial kit for this one. Now I come to molecular genetics. One, do we need molecular genetic testing? We needed to confirm the suspected diagnosis, but it is not needed if the patient presents with typical symptoms. It's a waste of money. It's important to test the siblings and sometimes also parents and children of the index case. In unclear diagnosis, it depends on the level of your suspicion. If there is a patient with low seroplasmin, but otherwise normal, you may want to see if the patient has a mutation. I'm not so sure this will help you much, but anyway, you can do it. But it is not a screening test for Wilson's disease. That's what I get all the time in my lab. I don't do it anymore. You cannot screen a healthy person for Wilson's disease because you cannot even make a clear statement what it means. There are big problems in the interpretation of results of molecular genetic testing. What is the definition of a disease-caused mutation? This goes far away from my topic today. This applies to any type of genetic analysis. Many common mutations are tested with functional assays. Then you can say, yes, we know it's a mutation. You can compare the frequency of a particular mutation in patients with healthy subjects. So we need at least 100 healthy subjects. And if it's only found in Wilson patients, it's quite likely a disease-causing mutation. And then you have a number of databases, which I can recommend to you. It takes some time to understand them. There are 20 databases. I'm using CleanVar and Varson. These are my 2 databases I'm using. And the other question is disease presentation. Does detection of homozygosity or compound heterozygosity means that the patient has the disease? Like in many other genetic diseases, disease penetrance in Wilson's disease is unknown. And if you find only one ATP mutation, what does this mean? Is this patient really an asymptomatic heterozygote? You see, you have to put all the data together to come to a diagnosis if you enter genetic testing. So therefore, we proposed a diagnostic score. You score the presence or absence of calcification rings, low seroplasmin, the presence of typical neurologic symptoms, the amount of hepatic copper, the amount of urinary copper excretion, and the presence of mutation from 0 to 4. And then you add up the score. If your score is greater 4, then it's diagnostic. You made the diagnosis. If the score is just 3, the diagnosis is possible. You have to do more tests. A score below 2 makes the diagnosis unlikely. So at the end, we come to treatment. Basically, we have different ways to treat the patients. We can chelate or bind the copper and get it to excretion. The most commonly used drug is penicillamine. A new compound I'm going to discuss with you is tetrathiamolybdate. You can inhibit intestinal copper uptake by zinc acetate, and the ultimate stage, you may have to replace the liver. The question is this evidence-based medicine or eminence-based medicine? There are not much data to support any types of this treatment. And I love this slide because it was 20 years ago, it was an issue devoted to Wilson's disease, and then Brewer said penicillamine should not be used as initial therapy for Wilson's disease. In the next article, Dr. Walsh, who discovered penicillamine, the treatment of first choice for patients with Wilson's disease. So these are the experts speaking, eminence-based medicine. And the editor had a hard time with this paper. And he said penicillamine is a controversial treatment for Wilson's disease. Unfortunately, not much has changed since. The newest kid on the block is this compound, this bischoline tetrathiamolybdate under the name Alexion 1840. And they have finished just a phase 3 trial with this drug, the so-called focus trial. And basically the press release said that this drug demonstrated approximately 3 times greater copper mobilization from tissues than standard of care treatments. And you see what is tetrathiamolybdate dosing. You see here the chemical formula in the middle is molybdate and 4 sulfur atoms. And they form a tripartite complex with copper, albumin, and with copper and albumin, which is excreted in the urine, and partly, and that's very important, excreted by biliary excretion, the normal way to get rid of copper. Detailed results of this study are not yet published. I know some of them, but I am bound by confidentiality not to say more than this. So if you took guidelines, I think the EASL guidelines say the initial treatment for symptomatic patients should always include a chelation agent, penicillamine or triantine. The most important point in long-term treatment of patients is adherence to treatment. Compliance is the key to achieve good treatment goals long-term. It's very important to symptomatic control, to have normal transaminases and good copper balance. And this is a very nice slide from the large Polish group on Wilson's disease, and they have looked for the time for the probability of symptom-free if the patient takes the drug or the patient does not take the drug regularly. And you see, even after 20 years, only 10% of those patients who do not take the drug are free of symptoms. And there was a very high mortality among them. So I think the most important issue is not so much what drug you choose, but to tell the patient and monitor the patient that the patient is taking his drug. Monitoring should include the clinical outcome, like liver tests, elastography, neurologic testing, determination of the 24 urinary copper excretion. The ideal approach is to do it after 2 days of drug holiday, and calculate the free copper I mentioned before. The current methods are not very reliable, but we hope to get better methods. This shows you the evolution of fibroscan in patients with cirrhosis. Without cirrhosis diagnosis, it's a follow-up for almost 20 years, and you see there was no change. So the patient remains stable if they take the drug. In patients who had cirrhosis and diagnosis, again, they also remained stable or even become normal, except of this patient. This worsening was due to an intercurrent unrelated disease. You can have other forms of elastography, like shear wave elastography, acoustic radiation force, impulse imaging, and magnetic resonance elastography. Whether they are better remains to be seen, but a fibroscan in our hands is a quite good methodology. And to end up, Fulman-Wilson's disease is the indication for liver transplantation. It's not rare. It accounts for 1 out of 6 cases, at least in Europe, of high urgency liver transplantation for acute liver failure. So it's in the same range, for example, as hepatitis B. Obviously, any form of decompensated cirrhosis, like in any other disease, is an indication for liver transplantation. Neurologic disease is not an indication for liver transplantation. A very important question, can you do living donor liver transplantation? Because if the parent gives a part of the liver, the parent is a heterozygote. It has been done in Japan with good success. So my take-home message, therefore, is diagnosis of Wilson's disease is a major diagnostic challenge. It requires at least 2 typical findings. According to the Wilson's disease working party in Leipzig, published about 20 years ago, and part of different guidelines. And a very important message, it makes sense to diagnose the disease because Wilson's disease is a treatable disease. Initial therapy should include a copper chelator. None of the available drugs were tested by a randomized controlled study, the exception being tetratiamolybdate, but these data are not available. And you should go for liver transplantation if the liver fails. Thank you very much. Okay. Hello? Was it okay?
Yes, Dr. Ferenci. Yes, I'm there. Everything is fine. And we have your recording.
That's good. And what is the time when it's presented? I'm not so sure whether I can be online to answer questions, but if you give me the time and the link.
Yes, I'm going to send you an email, which will specifically highlight your talk. It will be in Pakistan time, but I'm going to add I'm going to add a line which will let you know the time in CET. All right.
Okay. Okay. And the link.
So,
yeah, if I have time, I'll try to be online during my lecture.
That would be so kind of you if you can make that, but it's on your comfortability. Now that we have your talk, it will be it is very convenient for both of us. So we can make it more convenient for you. Thank you very much, Dr. Peter.
Okay,
I'm very happy to see you. Bye-bye, see you.
Wish you a successful meeting.
Thank you very much. I'm sending you an email shortly.
Okay.
Goodbye. Arva, meeting end kar do. Hello.